All right, they said we live. Let's go over
Yeah,
here to
I see we
Facebook.
live and shit. All right, everybody, welcome to the Nurse and Nurse podcast with Starshima and Kevin. Fuck all you bitches. Thank you for being here, though. Woo! I told Starshima I'm on fucking fire tonight, so if I piss anybody off, I don't give a shit.
Are you on fire tonight, Kevin? Are you
Woo!
are you fired up? I'm checking the stats over here. I love it. I love it. Let me just fix my Facebook here.
Oh, that's good. I hear an echo and shit though. Just so you know that. That's because you're live and stuff. So can you say something so I can make sure I can hear you?
I'm here.
All
I
right,
was
all
just
right. So
I
we're
because I
gonna.
was I was looking on my Facebook page.
Oh, is that you on?
Um,
Is that you on Facebook? We got
yeah,
one live
that's
viewer. That's
that's
fucking
me.
you, huh?
That's me. Nobody else is listening to us at the
Woo!
moment.
That's all right. That's all right. They'll
Okay.
fucking catch up on the recording.
Yeah,
We're
they'll
gonna
catch
talk.
up on their side.
Yeah,
Go
we're gonna
ahead.
talk about medication errors in nursing because I'm very passionate about medications, and I think that fucking most nurses suck at their meds. I don't blame nurses in general. I do blame the schools, but I do think that nurses should get a damn drug book and stuff. I have the Drug Davis app on my phone. It's only like $40 a year, so don't be cheap and shit. Get a damn drug book. How's your week been? We haven't seen each other. I guess you had a hard week and shit. Life kicked you in the ass, and you
Man,
feeling sorry
Kevin,
for yourself and stuff. You need a fucking hug.
I need a hug. I need a hug, virtual hug.
Mm.
Look, got
Yeah,
nurses
let
who
me hug
support
and
each
shit.
other, right? Oh,
Mm,
yeah.
mm.
Nurses who support nurses. But shoot, Kevin, I just really been in a season where I just really feel like I must be in a place of exponential type growth because I feel like that rubber band and that comfort zone is putting so much tension on me. And it kind of reminds me of that time when I was in healthcare, bedside nursing, of when I was ready to make a shift. Like it's like a growth type thing. And life sometimes. What's up, y'all? Life just be
Like,
getting
yeah, thank
me.
you for joining us.
Yeah, thank
Life
y'all for
is life.
joining.
Yeah, life is life. Quit crying and shit. Somebody's
But
testing your patience.
right. Life is testing my patience, and I appreciate that
Yeah.
because, again, like I said, it's growth. But I really appreciate even just having a community of people to really support me or people that I can be truly authentic with. Surprisingly, it was a time in my life when I used to be afraid to tell people that I was going through things or I was having a hard time because it just seemed abnormal, whether it was in nursing, whether it was in my career, whether it was in my life.
Wait, I have a question. Is that a
Yes.
cultural thing?
It could be cultural, that strong woman thing as well, right? Like this was just a thing. I'm not supposed to show vulnerability, and I think a lot of people have a difficult time of showing vulnerability. Like, are you okay with being vulnerable?
I don't even know what that fucking word means. So
See, so is it cultural?
No, I think just from um I just think that from what I learned growing up, getting my ass kicked and shit, that I taught myself to rely on myself and not others. So maybe I don't have that need for vulnerability. And maybe that's a weakness. You know what I mean?
Yeah, like your
Could,
strength,
could
like
be
being too strong.
yeah, could be a
I don't,
weakness, because I don't really rely on people. I don't trust people. I don't trust motherfuckers to save my life. I
but
trust
we
one
need
person.
people.
Do we?
We do need people.
You need somebody. Who do I need?
We you need people.
I only
You
need
need people.
Miss.
Think about this.
I only need Miss Pat to fix my LPD.
Oh Jesus, Miss Pat, I hope you listen to this. Come get him, Miss Pat. Come find him at the
She
office.
just needs to fix my LPD. That's all she
But
needs to do.
we need people. I think vulnerability is our greatest strength. And you know what? I think that this podcast has allowed a lot more nurses to be vulnerable and share
Yeah,
areas of weakness and areas of where they need support to be able to help them grow.
yeah,
I
but
think vulnerability is a strength, but we have been conditioned to think that vulnerability is a weakness.
I don't know if it's a weakness or they just see it as this is my problem though with nurses. And I know I'm in a female dominated field, so all you female nurses don't kick my ass too much. But I think the problem is you feel like you can't speak up. Because Miss Pat had the same problem when we first met. She worked at the Madera County Office of Education, and she'd come home bitching all the time. But they don't give me this and they don't give me that. And I said, "Well, did you fucking ask?" Oh, I can ask. I'm like, "Yeah, ask. What's the worst thing you're gonna fucking say?" No. I said, "Okay, but have you lost anything?" So then when she started asking, she started getting everything she wanted. But I think nurses are afraid to ask for what they want, what they need, because they're afraid of looking weak.
All
And I
right.
don't,
So that's what
I,
I'm saying. Being a
yeah,
little bit of vulnerability. Tell me what you
yeah.
need, sis.
Yeah, but we're fucking not mind readers, you know. Men aren't mind readers, ladies. You got to tell us what you want. Like if you want a fucking iPhone 12 with the orange case, take a picture, send it to me, and tell me what store to buy that shit at.
And then he's gonna buy it and send it to you. If
Yeah.
y'all, Kevin, you are hilarious. Well, we as women, I think that this podcast is giving women as well as men a voice, right? In how to speak up and to deliver better quality of care, which is going to be a good segue into our conversation today. And what did you name the title of this podcast today, Kevin?
Medication administration errors in nursing, because I think nurses suck at medications. They don't really always understand their medications. We have a lot of med errors because we rely on pharmacy, we rely on other people. I think nursing schools don't teach us. I think they've cut out pharmacology altogether, or they've downgraded it so significantly that we kind of suck at meds and stuff. Now I
Okay.
will tell you this, because I'm trying to get here to the podcast while we're talking and stuff. Because you asked a question a couple of days ago. You
Mm-hmm.
said, if you could wave a magic wand and change one thing about nursing profession, what would it be? And I can tell you, out of the 8 comments, they all had the same theme except for one.
Hmm. What was the theme?
Can we be nicer to each other?
Hmm.
Now, that's something that nurses, and I'm going to blame it on female nurses. You can be mad at me all
Don't
you
blame it
want.
on us.
I am. I'm blaming it on you.
It's on you
Because,
guys.
nope, nope, men don't behave in this fashion.
Mm.
You guys are not nice to each other. Like you tell me that when a woman gets mad, what do they want to do? If you get super mad, what is the natural response a female wants to do?
Cry.
Right. When you get happy, super happy, what do you want to do?
Laugh.
No, you want to cry too. And when you get sad, what do you want to do?
Cry.
Cry. What do women love to do? Cry. And it's a
Mm.
natural thing. It is. It's a natural thing. You don't say that because you have learned to hold it in because you've been taught by your nursing professions and your colleagues that it's a weakness. And
Mm.
it's not a weakness. It's a natural phenomenon.
Mm-hmm.
And so when you hold it in, you're going against nature. And
Okay.
it's just I think that's why you get mad at each other. You get all cranky and shit.
So you think that we don't know how to handle? Let me unpack this.
I
This is
didn't
what
say you
I'm.
don't know how to
So
handle.
do
Don't
you
be
think that
fucking put
there's some
words in
little
my mouth.
emotion? Well, I'm just trying to pick up what you're putting down in your nice, sophisticated, fancy ways in which you're saying this.
I'm
So what?
saying if you need to cry because you're happy, sad, or mad, then fucking cry. Who gives a shit what other bitches think? But why you women always go out like you? That's your brand, nurse Starshima brand, nurse coach. Let me
Nurse
help.
to see.
Okay, but let me help elevate women. That's your
Mhm.
fucking brand. Is that
Yes,
not true?
that is
So
true.
then why do nurses, female nurses, beat each other up and eat each other up? How
I
I thought women wanted to fucking help each other and shit.
Well, here's the thing. If you want to go deep, so I
See?
believe that
Mm-hmm.
we as
Let,
women
let me take a drink.
take a drink. We ain't gonna even ask you what you're drinking, okay? Coffee,
Coke,
Coke.
soda.
As long as it's Coca Cola and not Shasta, we are right.
I like Shasta too. RC Cola,
We too
Mr.
bougie.
Pibb.
We too bougie for Shasta. I'm just kidding. No, but I really feel so. Here's what I think that was a good that's a good question that you just asked me. But what I really feel that it is that women have been competing since the beginning of time,
Competing against
and
each other for what? You
because
got the
it's
same
something that's
motherfucking
been
job.
ingrained in us, right? And then also that emotional intelligence, that we're so emotional as women, so to be able to handle our emotions, we don't always feel comfortable with sharing and articulating. That is the
Because you're
inner work
afraid
of
of
an
getting beat
individual.
up by other fucking female nurses.
Well, I don't
So
know if
look at this.
about getting beat up, but
Yes, you
just
are. Because look, I'm going to read all the comments here and I won't tell you the names. Improve safety for patients, staff in all areas. That's one. We
hmm
would be nicer to each other, increase wages. For some RNs to start treating LVNs like nurses and not getting pissy when we ask for their help.
hmm
The attitude and backbiting, decrease unit drama. I mean, it's all the same shit. Like, why are you beating each other up?
Yeah, but do you know that studies show that like bullying in the workplace, nurses eating their young, like where nurses will make LVNs feel like they're more valued or not chew us out when we ask a question. Do you know that that starts in nursing school
Yeah, I agree with that. That's
and it
because there's
travels over
that's because
into the
there's
culture?
some that's because there's some nursing instructors who are RNs who even they teach LVNs like you. I'm not saying you're one of them, but you do teach LVNs too, don't you? Right?
I do.
Some nursing instructors that are in your position, they talk down to those students because they're just LVNs and they're not real nurses.
Right. But here's the big thing.
Maureen Stevenson, she just posted and said environment. Okay, Maureen, I love you, but tell me what the hell that means. Like, I'm a man, I don't understand that. What does it mean, environment?
But
Be more
also here's the
specific,
thing.
Maureen.
And here's the thing too, Kevin.
I love you too.
Here's the thing though, friend. Listen, my brother. I really believe we don't do the inner work.
I don't know what that means. I'm a man. Explain that to me.
You understand what I'm talking about.
I don't know what that means.
The going inside. Like I feel like a lot of the cattiness, a lot of the attacking is because we don't know who we are.
And then bullshit.
Also we compare ourselves laterally, we compare ourselves down, and we compare ourselves up. And we have to in the profession. As a profession, I see men do it too. So we in the profession,
if you see a man do it, that means he's a bitch.
We just had a conversation offline.
Most men go to work, they mind their fucking business, they do their job and go to fuck home because we don't have time for that shit.
But here's the thing though. I that's what we want to say most men, but most men have not done the inner work either, and they're just insecure.
I haven't done the inner work.
They may appear outwardly strong and they are inwardly weak.
I'm okay with that. I'll admit that shit. I'm outwardly strong, innerly weak, but I
didn't say it was
Hold on. I'm telling you. I'm confessing now. I'm outwardly strong. I'm innerly weak, but I would never make you fucking feel like shit at work unless you're dumb as a box of rocks.
Well, people do it every day. I see men do it to women. I see women
in the nursing field.
In the nursing field. We just had a conversation offline in the green room.
I know, but that's one person.
Similar.
I said the majority of men don't behave in that fashion. And if they do, like the person you and I were talking about, they a fucking bitch. Because most men don't behave that way.
Okay, that's fair.
But Maureen said maybe the environment fosters that type of behavior. Yeah, but are you saying that nursing in general fosters that type of behavior? I don't know, Maureen. I just think that most nurses are either assholes or they're not. Like, I'm a nice nurse. I don't treat people like shit unless you're dumb as a box of rocks. And I give you the benefit of the doubt. I would never be mean to you, Maureen. If you came to work and you were having a hard day, you were crying, I wouldn't be mad at you. I'm like, why are you crying for, Maureen? You okay? What can I do to help your ass?
So let me ask you this, Kevin.
But I wouldn't treat you like shit, Maureen. I wouldn't make you feel less than you are.
Hopefully not. You're not that.
I wouldn't, because that's stupid. I mean, I don't know what's going on with her life.
So let me ask you this. What can we tell our nurses, our young nurses, our nurses that are seasoned, who are out here, who are finding themselves in these environments? And I feel like it's a level of toxicity, right? So they probably can't perform at their optimum. They probably can't calculate their dosage of their medications correctly, right? Because the environment is toxic. Like, what can we tell them right now to help them navigate and show up and still deliver quality care?
Put your motherfucking blinders on. Stop worrying about the nurse next to you and all their fucking drama and deal with your patients. You walk through the hospital door, you have one goal in mind, and that's patient safety. Quit worrying about all these other bitches.
But don't you have to have some type of ability to be able to collaborate with your coworkers?
Why do I need to collaborate with your ass? If I need your help, I'll ask it.
That's collaboration, right? To work together.
But if I don't need your help, I'm not going to bother you. I'm not going to go and get in your drama. I'll give you an example. I'll give you an example. I won't mention her name, but some nurse asked me for help recently. Mm-hmm. And they had a lot of drama in the situation. And I told her point blank, I do not want to be involved in your drama. Mm-hmm. I'll help you, but I'm not going to get involved in that drama. So until you fix that drama, don't ask me for help because I don't want to get involved in your shit. Mm-hmm. If you're too weak to go and address that person that you're having drama with, don't make me do it. I'm not your savior and Lord and shit. I'm not your knight in shining armor. You go do that shit. You're a grown ass woman. Why are you asking me to do that? Is that not fair? Yeah,
I think
so
that that's fair. I think
yeah,
that we all, because we don't like to deal with conflict, right? Conflict resolution is so hard. It
I
feels
say
uneasy.
I
And
say it
then
every
again,
time.
it leads to people, it leads to error, it leads to patient. Um,
Females don't like confrontation,
right.
Starshima.
But we like, sometimes we can be catty,
But
right?
don't see it as confrontation, see it as patient safety,
Patient
patient
safety.
advocacy. I'm advocating for my patient.
I like that. I like that. Remove
Right,
the emotional aspect
right,
out of it.
right. Quit being
Yes.
emotional shit. You're there to do a job. Your coworkers are not your friends. If you die tomorrow, they would not give a shit about you. They wouldn't even know who you were. Who's
Well, I
that
hope
fucking?
that my coworkers care
They
about
won't.
me.
You
I'm
can,
just
yeah, they
kidding.
don't. Keep lying to yourself.
Maureen says she loves that point of view, Kevin.
I
Look
love you
at you
too,
drop.
Maureen.
Look at you dropping gems.
I love you, Maureen. I love
You
you
know who
too.
Maureen is?
I'd have to see her face. I can't see her face. I'm scared. Look, Maureen, I'm scared to click on shit because I don't want to go away from the podcast.
Oh my gosh! All right, Kevin. So let's talk
All
about
right, let's
it.
talk
Was
about
it was
medication there. That was
Let's talk
nice.
about some
Yeah.
medication error. I think we had a good 16 minutes of intro with our guests. Let's talk about medications errors. Let's unpack this. So why do we think why is this topic probably important for us to have a discussion about? We got a community of nurses who want to learn from us, who want to grow, who want to drive better quality care. Why perhaps did we pick the topic of medication administration?
Because nurses suck at their medications. I don't care if you're an LVN, and this is just my opinion. Y'all can be mad, you can disagree. I don't care. But I think most nurses, RNs, LVNs, they don't respect medications. They don't understand their medications. When I went to nursing school, and I know I'm old as shit, but they made us do drug cards. Do you make your students do drug cards? I'm gonna
Not in
put
my
you.
class, no.
See
Not
what I
the class
mean?
that I teach is it's not
Right,
appropriate for them to do.
but does your program require your students to do drug cards?
I believe it does.
Right. And
I
they're
can't
asked,
speak to it because I don't know for sure because I don't teach classes that
well,
require
I
it.
know they do. I already know the answer to the question I'm asking you.
So why you
But
asked? Just
because
kidding. Okay, I'm sorry. Go,
no,
Kevin. I'm sorry.
no, so they're made to make 50 to 100 drug cards. But then what do they do with their drug cards once they make them? What do they do? Do you know?
I don't know. I kept mine for a while, but I threw mine out too.
Okay, so when you were a nurse in RN school, did your
Uh-huh.
instructor make you make drug cards?
They did.
What did you do with them?
I put them on. I don't know the proper name of it. The
Three by
little
five
ring.
cards. I
Yeah,
got
three
all
by
that.
five index
But
cards. Then
but
I
what
put a
else did
little
you do with
ring
them?
on them,
Mm-hmm.
and I would put them in my pocket,
Mm-hmm.
and I would take them to clinicals with me. Every single clinical.
Okay.
Hmm.
So when you got on the fucking floor and you started passing meds,
Yes.
before you started passing meds, did your instructor say, Starshima, what the fuck med are you giving today?
She didn't say it exactly like that, but she did want to know what man I was given.
And did she ask what is the mechanism of action?
She did want to know.
What are the
Yes,
side effects?
absolutely.
What are the dosages?
Yes.
And if you didn't know any of those answers, what would she do?
She would not allow me to pass the med. I would have to
They
go
don't
back and
do
look up
that
the med.
anymore. They don't do that anymore. They don't even
Oh,
ask the nurses that. And that's why they suck at medication. All they do is make them make the drug cards and then they tell them they give them a grade and they go away.
okay. Well, I know that I teach about safe like dosage, right? The calculation aspect of it. And one big thing for me is putting emphasis on making sure we as nurses can draw the connection as to why we're given a medication. I believe that sometimes we think medication administration is just an intervention, right? It's just a task like giving a bed bath. And we fail to do the things like a good nursing assessment, making sure we do our good nursing implications before we give a medication, right?
I got you.
So I think that nurses, oh, you put your
Mhm.
your three in the chat,
Now
right? So
don't
I won't
hold
say
on.
anything. So I think that we miss that connection, which is leading to some of the errors that are widely known for our nurses, which is like or given the wrong dose of the medication, not knowing the proper dosing for our patient, missing doses doses of medication, not understanding the importance of why patients need the medications when they need them, right? And then wrong medications to the patient are some of the most commonly reported medication administration errors amongst our nurses. But I really feel that we have to draw back in, because I really feel a drug is the easiest way to kill a patient. And once
Yeah.
the drug is there,
Yeah.
some things have reversal agents, some things do not. And
Okay,
once it's there,
so I'll ask you this.
no.
I gave you the 3 medicines that are in the chat box for all you people. Now, people don't go out there and fuck shit up and tell everybody. Give people a chance. What do those 3 medications have in common? And what is the antidote? And don't cheat. Don't go look on your drug book and cheat. If you don't know right off the top of your head, just say, I don't know. But I can almost guarantee that most people don't know what the antidote is for beta blocker overdose.
Do you want me to say it? I mean, I
No.
don't know what it is.
Do you or
I'm
don't you?
guessing.
Don't
Huh?
say it. Don't say it then.
Don't say it.
We'll do it at the end of the show.
Okay. So he put 3 medications within the chat box, and he wants you to know what
What
do
are
these
they?
medications have?
Mhm.
What are they? What do they
Mhm.
have in common? And what is the antidote for them?
Right. And I
think
can
I know
guarantee
what
you
the
that
antidote.
I guarantee that most people don't know it. And then my question to you is, if you're given that medication, whether it's PO, definitely IV, and you don't know the antidote, why the fuck are you giving that medication? Because once you
Right.
give shit IV, you can't what?
You can't. I mean, you can't turn it around. You got to have an
Right.
antidote if it got something
Right.
to bind it. But
You're totally fucked.
right.
So
That's the thing I was explaining to, my students, is like trying to get that in this new nursing generation. I feel like, being able to impact the bedside from beyond the bedside, even what you do, you're an educator as well, right? You're teaching new nurses. Some may be not nurses yet that are coming to you. Some are seasoned nurses. Some are, baby nurses in the profession. Is the ability to still drive that impact at the bedside and really helping them understand the importance. I think a lot of changes are starting to happen in healthcare secondary to the board not feeling that nurses are coming out competent, able to think well, critically think, is when they're doing interventions like giving medications to patients.
Yeah, but that's
that
the
are
board's
causing
fault.
fatality.
That's the board's fault for not going out and auditing the schools to make sure that they're teaching information correctly.
Right. And then if that's the case, then how are they passing boards? If
anybody can pass a fucking test. Anybody can pass a test.
Mm-hmm.
Anybody can pass a test. I'll give you another example. How about the Mona? What is Mona? MONA.
Morphine, oxygen, nitro, Mona, aspirin.
Why are we still teaching that shit? We haven't used Mona for almost 10 to 15 fucking years.
That's the way you treat your chest pain patients.
Mona is a dirty slut. She kills people. Tell Mona to turn her ass around, because what drug should you give first for a heart attack victim?
A vasodilator.
Nope. See, that's
what
wrong.
Are you giving?
Tell Mona to turn her ass around, because what should you give first?
You're going to give aspirin?
Right.
But, I was reading one NCLEX question.
That's my point. I get that, but that's where we're teaching people incorrectly. That's why we got fucking nurses, because you got old-ass nurses writing the NCLEX who haven't been on the floor for 100 years, teaching shit that we haven't done for 15 fucking years.
Right, because I was reading the NCLEX question. I can't remember exactly how it was written, but it was around a chest pain patient,
right?
And it was around giving morphine, oxygen.
So what happens? What happens if you give morphine and nitro to a patient and you haven't done a 12-lead EKG?
Well, it's a vasodilator. Both of them will vasodilate, so it's going to change.
So what happens? Well, what happens if the patient's already having a right ventricular infarct?
Then you're going to make it worse.
Yeah, say it again.
Make it worse.
Right. If you don't fucking teach people that, they won't know it. So all you're teaching them is Mona. That's what they remember out of school.
Well, so you always should get an EKG first.
Right. Because you want to know if it's right-sided or left-sided.
Yeah, because you can make treatments look a little bit differently, right?
Right. And if you give morphine or nitro before you do the 12-lead, what did you just do to the 12-lead?
It made it invalid. Well, you changed it the way it looks because of how
why
the
don't we
works.
teach that? Why don't we teach that fucking in school, Starshima?
Because
why don't we change the motherfucking NCLEX, Starshima?
Because they tell them to give them the acronym is Mona.
That's because the people still in charge are old as fuck and they don't understand that shit.
Yeah. But here's the thing, though.
I'm old. I'm one of those old nurses, but how come I know this shit and they don't?
Okay. So that's true. But you're very much more advanced because you are an educator.
And no, because I can read a motherfucking book. I can read a fucking book. I can read some damn research. I ask people who are smarter than me. I ask doctors, cardiologists, nurses. I ask, I'm like, why do we do this? Why don't we do this? Like, there's a new study now with ventricular fibrillation. You
Mhm.
give a dose of epi and you give Esmolol.
Okay.
Why would you give Esmolol to a dead person? What is Esmolol going to do?
Decrease the demand. I don't know. What is it
Yeah,
doing?
say
The
it
demand
again.
of her creates
Yeah, but
decrease
it
the demand.
relaxes. It relaxes the ventricles so the
Mhm.
epinephrine can work more efficiently.
Hmm. Makes
I'm like,
sense.
oh, I know. I'm like, oh shit, that's fucking smart as shit. Like,
Hmm.
but how come we haven't done it sooner? Because most
Studies.
nurses, yeah, I know, but most nurses don't read studies. They wait to listen to the doctor. They wait to listen to the pharmacy. How are we going to improve our profession if we don't take it upon ourselves to get educated and understand the pathophysiology and all that shit about our meds?
I agree with you. And in understanding how the medications work to make sure we go back to that very foundational aspect of nursing before we do any
I love you,
intervention.
Maureen. I want to bite you, Maureen. I love you. If I wasn't married, Maureen. I saw your picture too, Maureen. I love it. And yes, Maureen, I am updated because I stay up to date. Do you know Maureen? Am I gonna get in trouble?
All right.
uh,
But I think that before we put any intervention into place as nurses, it's important. It goes to the very foundation, but we just do the thing because we see it on a piece of paper and the doctor ordered it. So I'm just going to do it without understanding what is this a desire to do? Did I weigh out my alternatives and what do I expect to see that's
because we're
happening in the
because we're
patient?
because we're not taught to think that way. In medical school, doctors are taught to think about algorithms. That
Hmm.
hurts nurses' brains. Nurses hate algorithms. So
Right.
I stopped calling them algorithms and I call them pathways. Because
Clinical pathways.
that's even better. I'm gonna steal that shit. Clinical. Oh, okay, Maureen, but I won't tell. I won't tell if you won't. So clinical pathways. I'm gonna steal that from you now. So what they do is they go down these pathways. Pathway A says if I do this, I have this risk and this benefit. Pathway B says if I do this, I have this risk and this benefit. Pathway C says if I do this, I have this risk and this benefit. Which one has the best benefits with the least risk? That's how
That's how we,
physicians that's
yeah.
how physicians are taught though. But we're not taught to think that way. We're taught to fucking react and give medications and treat the patient without assessing first. And that's
That's not
craziness.
okay.
I know it's not
That's
okay.
backwards. That's unsafe.
But that is called task-based medicine, not evidence-based
Well, I
medicine. And
don't teach my students. I don't teach my future nurses that.
that's because you
I teach them
understand. That's because you understand what? Evidence-based medicine.
because Kevin, that is not okay. We have to
I,
know how to look and assess our
so then
patients
why
before
how do we
any
get the
intervention.
rest of the instructors to do the fucking same?
Well, we are just here to change the world and to change
I'm
the face
trying.
of
I'm trying to
education.
change the
Just
damn
kidding.
world.
And future nurses
So let's
and how
talk
we
about
nurse.
yeah. So let's talk about medicine. So I gave you earlier in our chat box, just our private chat menu. I gave you the acronym PINCH.
Pinch.
I'm gonna write that in our. I don't know if you can do it. Maybe I
I
should
can
try to.
do it here. I can do it here.
Yeah, on Facebook and shit.
PINCH.
What
Pinch.
the hell does pinch mean? And yes, I don't mean pinch your butt. I don't mean pinch
Kevin.
your butt, Maureen. Don't make your husband come and shoot me, Maureen.
So the
What
P
does
is for, what's the P stand for?
I don't let's see if anybody knows. Let's don't.
Oh, I put it in the chat box
Oh, all
already. I'm
right. Well,
sorry.
P. That's all right. P stands for potassium. What about the I? What's it stand for?
I stands for insulin.
Insulin. What about the N?
The N stands for nitro.
The C?
What was the C for it?
Chemotherapy.
Oh, chemo. I was like, what was it the C for again?
And I'm sorry to all the chemotherapy nurses, but I can never be one because all the chemotherapy nurses I've seen on the chemo floor are losing their hair and look old as shit because you're giving chemotherapy without gloves and proper PPE. Where you damn PPE? And
Kevin,
then it's okay, they'll love me. And then the H is heparin.
I put it
It's
in the
true though.
chat.
Yeah, I see it. So heparin.
Uh-huh.
So what do we do for potassium though?
What do you mean? What do we do for
Remember,
it?
I asked you what is the proper way to administer potassium intravenously?
We should push it.
Never
quickly
push.
in less
Never.
than 30 seconds. I'm just kidding.
Oh, I do ask that though. No laugh. I do ask that. I do ask that though. Where's the only place that you can push potassium? Because the doctors still order that, believe it or not, Starsheen. You'll still get an
The
order. It's a
place that they
common.
can push it in a prison. No, I'm just kidding.
No, that's right. That's right. Where specifically in a prison?
The lethal chamber.
On the death row. That's right. That's exactly what they do on lethal injection. They give like 160 milliequivalents of potassium IV push. That is true. Did
Takes
you
them
know that?
out.
Yeah, that is true. So,
Yes.
so that's true. So, but how, if you gave potassium intravenously, how much can you give
In a peripheral IV,
in
you
a
can give
peripheral
10
IV?
milliequivalents. Diluted. It's diluted. Sorry.
Okay, but if you dilute it, is it pre-diluted from the pharmacy or can you dilute it yourself?
It typically comes pre-diluted from the pharmacy. They generally as nurses do not need to dilute the potassium.
If you do have to dilute it, what are you going to add to it?
You're going to add normal saline.
And if you do add normal saline, the Board of Nursing considers that
a medication.
So that means you need to order for
yes.
For the normal saline. So how much per hour, how much milliequivalents per hour can you give potassium in a peripheral IV?
I feel like I'm being quizzed like a new ER nurse. You can give 10 milliequivalents at that pump, 10 milliequivalents over 1 hour. That is the max amount you can give.
And what about a central line?
Central line, according to Kevin, you can give 20 milliequivalents over 2 hours.
Not according to Kevin, according to the Infusion Nurses Society and the Davis Drug Gap that I have and shit. You can give 10 milliequivalents per hour via peripheral IV or 20 milliequivalents per hour via central line. All right, so let's go to insulin. What is the only insulin that you can give IV?
Regular.
What is regular insulin? That's right. So how much insulin can you give? Like how much is too much?
It really, well, I know the facility that I was at, we had a equation that we had to formulate to determine.
So that's if you're doing, but that's if you're doing a drip. And that's where nurses get mixed up because most nurses, their brain default, and I don't mean you, but most nurses, their brain defaults back to the sliding scale. When you're talking about a sliding scale, that's talking about IM sub-Q. If you're talking right. If you're talking about an IV drip, they have a formula. I don't remember the name of the formula, Chicago formula, so I don't remember what it's called. Yeah, it's the name of a formula, but it's blood sugar minus 70 times 0.0.
The sensitivity factor for
the sensitivity. Right.
Yeah.
But what is the max units per hour you can give?
Shit. I don't know. Some of these patients can get 500 units per 1 ml. No. So that could be it depends. What's the max?
That's not true. If you look at the drip factor, the sensitivity factor that we're talking about, 20 units per hour is the max.
Well, talking about sensitivity factor, what, 0.1?
It doesn't make a difference. It doesn't make a difference. So if you did blood sugar minus 70 times 0.02, blood sugar minus 70 times 0.03, if it comes out more than 20 units an hour, you don't give it. That's all you can give. And you do that for 2 hours, then you change the sensitivity factor.
That sounds about right. Yeah, you go up because when they don't meet goal, you change the sensitivity factor.
Right, but you can never give more than 20 units an hour. That's if it's a drip. But what if the doctor says you got a patient with a blood sugar of 500 and they want you to give 20 units of regular insulin IV? See what I mean? But how many nurses would do it?
I don't know. I would be afraid.
Yeah, but I won't tell you the facility. I'm sure you know about the story. There was 2 nurses that they drew up insulin in the wrong syringe. And what happened?
They used the ml syringe versus the insulin syringe.
And what happened to the patient? You remember? You know the
probably
story?
They probably had a severe hypoglycemia.
You don't know that story?
No.
Oh shit! How do you not know this? I'm gonna put in the chat box just me and you.
Okay, put it in a private chat.
It is. Look at right there, the private chat. You don't know about that?
No.
So it's 2 seasoned nurses, and I know both of them, and I love both of them, but they made an error. They grabbed, at the place we worked at, they have the syringes right next to each other in the carts. You remember that? That person grabbed the TB syringe instead of the insulin syringe. And she or he drew up 10 units of regular insulin in the TB syringe, which makes it 100 units.
Yeah, because they're measured in their calibrations on the TB syringes in
And
the
you and me
100.
being friends, we work together. We're like, hey, Starshim, I'm gonna give fucking 10 units. And what did you say?
Okay,
Right.
that's
And
10.
yes, and I
Oh
pushed
my
it.
gosh, so unsafe.
I pushed it, and the patient spent like 6 or 8 weeks in the ICU, almost died. Which one of us got fired?
Both?
Nope. The one who said they verified it.
Oh, that makes
Why?
sense.
Why though?
Because that was a second nurse check. When
Not
you
just
say you
that, but
verified, you also said that you agreed to what was there.
not
You're the last
right.
person
Not
to
just
check
that,
off.
but you can get in trouble by the board of nursing because that's called falsification of charting.
Done.
Because you didn't
Well,
what?
maybe they did really think that it was 10 units in there.
Maureen says you're making me scared to go to the hospital. Don't be scared, Maureen. We're trying to educate nurses so you don't have to be scared. I'll be your nurse. I'm a professional bed bath giver, Maureen.
Kevin, you are a mess.
I'm trouble. I know. I'm trouble, Maureen. I'm trouble. Maureen says maybe if we have more healthcare, we have more healthcare system that focus on health. Yeah, that's true. I 100% agree. Every decision in healthcare, Maureen, is based upon money, not what's right for the patient. I can 100% testify to that.
Mhm.
So anyway,
True.
so just remember that regular insulin is the only insulin that you can give IV.
Yep.
How
Never
about
give
how about
Saudi.
how about Lantus insulin?
Never should be given IV. That's a long acting insulin.
So what if you mix Lantus insulin with NPH?
You shouldn't.
What happens to the Lantus insulin?
I don't know. I don't know what the chemical structure is, but you
It
should
it
not. The rule
uh,
is you should never
it
mix
makes
a
it
MPH and a long acting insulin with
it
anything.
makes it doesn't matter. Anything you mix with Lantus, it makes Lantus insulin inert. That's a fancy word I'm going to use for all you people out there. Inert.
Inert.
INERT. What does that mean? Inert.
Inert.
Mhm.
Not effective or more
Right.
potent.
Not potent at all. It makes it not work.
Okay.
So
Well, I
totally
guess
different.
that wouldn't be necessarily a bad thing in the sake of glucose.
Right. So
I mean, it's not like it's gonna make them a hypoglycemic,
right.
go into a hypoglycemia.
Right. All right. How
Yes.
about the N? The N stands for nitro. So,
Nitroglycerin. What does nitro do? It's a huge vaso.
right. It's a vasodilator.
Mhm.
So what's it do to your blood vessels?
It dilates them, makes
And
them.
so if I'm your patient sitting up like this, and you give me nitro sublingual or nitro paste, what's going to happen to the blood vessels in my brain?
They gonna vasodilate.
And where does all the blood go?
It's gonna drop. Your blood pressure is going to drop,
Yep.
and you're
But
gonna get dizzy.
where does all the blood in my brain go?
Where does it go?
Mm-hmm.
It's coming down this way, right?
Yes.
It's vasodilation.
So what does your
To the
brain
central
not
part.
have?
Less
So-
cerebral perfusion.
So what does your brain not have?
Perfusion.
I got that, but what
Blood
is your
supply. And oxygen.
see? That's a dirty word that you teach your students. I'm gonna scold you for that. Say it
What?
one more time. Say that dirty word again.
Blood supply.
Nope.
Oxygen.
Right.
Nutrients.
So let's go. That's a better word. So let's go
Oh.
back. I know, but it's better. So listen, when you
Nutrients is better than oxygen.
yeah, but why? Because why do your patients complain of headaches with nitro?
Well,
Because
because
what
of
is
the
your brain?
vasodilation. The
What does your brain not have?
oxygen. Nutrients.
See, yeah, I know, but
Perfusion.
I got okay, but I want you to understand so people will get this. So if your brain vasodilates and all the blood drops down, your brain doesn't have any glucose.
Oh,
And what
sugar.
happens? What right?
sugar.
Sugar. So what happens when your brain don't have sugar?
It becomes hypoglycemic and it can't do all the things that it needs to do.
Yeah, but they say that if you don't have sugar. So think about this. I don't know what you eat, but if you don't have your sugar for the day, what happens to your head?
If I don't get my what for the day?
Your sugar.
And then what happens to my what? My head?
Yeah, your brain. What happens to you if you don't have sugar?
Well, if you go
don't-
to some people get headaches like carbs. Like,
oh, imagine that shit. You get what? Say that one more time.
headache.
So that's what's fucking happening when you give nitro. Your blood drops down quickly. Your brain doesn't have glucose and nutrients, so you get a headache and shit. Yeah, you do get
Nice.
dizzy too, Maureen, but I don't care about dizzy. I just tell you, close your damn eyes.
Then they
But
pass
that's
out
why-
on the bed. You got them sitting
Yeah,
up next to you.
yeah.
Don't. You're like, what happened? I got dizzy.
Yeah, but I mean, I don't care that you're dizzy, Maureen, but I care that you have a headache because a lot of nurses don't understand why nitro causes headaches, but it's
Let me
because
ask you. Go
your
ahead.
blood flow drops down and you don't have a lot of glucose and electrolytes anymore, and you get a headache and shit.
So, is there a best way to position a patient when giving them nitro? So they give it to them sitting up? Should they lay them down?
Yeah,
What
just
would
lay them
you be
back.
the safe way?
Just lay them back a little bit. Put them at a 20 or 30 degree. You know what I
Hmm.
mean?
Is there anything that nurses should look out for when they're given nitro? Because sometimes we go and we put nitro patches on. We're giving these sublinguals over a period of
So
time.
so
How what can they
I'm gonna give
safely
a
look
dirty
out for?
secret here. I'm gonna give a
Okay.
dirty secret. I lie to the physicians and say we don't have sublingual. I'm sorry, Dr. Starshima, but we're out of the fucking sublinguals. We
Wait a
only have
minute, Kevin.
we only have nitro paste.
You
Why?
would put it on transdermal because it's
No,
not
but
going
why?
to.
What happens if you give sublingual?
It's highly vascular, so it enters the system really, really quickly.
So does the paste. But once you get sublingual, you can't what?
Take it back. At least you can take the paste off.
Right. So that's why I don't do it shit. Have you ever? You have heart problems?
No.
I know this sounds kooky. Maureen, do you have heart problems, baby? I know you have a heart problem because your heart aches for me and shit. But other than that, so if you don't have heart problem, I know it sounds kooky, but just take a little pinch. I don't know if you can see here. I'm gonna put it on camera shit. Just take like a little pinch, like that.
Mm-hmm.
Put a little pinch of nitro on your wrist right here, just a little pinch, and watch how you get a little dizzy. You won't pass out or anything, but you're like, woo, and it'll happen pretty fast. But how much do we put on our patients?
An inch, a half an
See,
inch.
right. We put a half inch to an inch. So if that little bitty tip right there makes you dizzy, what is that half an inch or inch doing to your patient?
Making them about to pass out.
Right.
So,
I'm not
so
joking. Yeah, I'm
yeah.
not joking. Every medication I give my patient, I taste it. Kxalate, potassium,
Oh,
liquid potassium, lactulose, Benadryl, prednisone. I know, but I taste it so I know what. I didn't say I take a dose. I said
you taste.
I take. Yeah, but what do I do that for?
So you can speak to the experience
Yeah,
that your
I know
patient may have.
exactly. Right, I know exactly what they're tasting, how they're feeling. I know it sounds crazy, but I'm not joking. Like I know exactly what they're tasting, how they're feeling, so I can empathize and say, "Listen, I know what this shit tastes like." But do you want to die from liver fucking disease, or you want to take your lactulose?
Nice, because that ammonia need to bind that ammonia. So hey, so for that new nurse, Kevin, who's given nitro for the first 5 or 6 times, right? They're a new ER nurse, new to the field. What would be some things that you would tell them to look out for?
Wear
To
motherfucking gloves if you're giving paste.
they learned that in nursing school. What else? What would a seasoned nurse reach back and tell themselves
Check the
around
blood
giving nitro?
pressure, check the map. Because map, most people go by map, but people don't understand what map is.
The
So
mean arterial pressure.
yeah, but you can say that, but nobody knows what the fuck that
Well,
means.
tell us what it is then.
Yeah, but I'm gonna dumb that shit down even more. Don't look at the map. Look at the difference between the systolic and the diastolic. Look at your blood pressure like it's a relationship.
Mm-hmm.
If I was your significant other and I'm always on your ass, like I'm this close to you all the time. Can you see me on the camera?
We can see you on the camera.
Now I'm asking you, if you and I are this close together, what's gonna happen to our relationship?
Sorry, I was distracted. Say it
I
one more
know.
time.
Excuse me, sir. Can you can you stop ignoring? You're ignoring me here, and I don't like that. I'm jealous, sir. What's your husband's name?
Damone.
Damone, can you stop bugging your wife, sir? I have her for the next hour. And don't be jealous, Maureen. Don't be jealous. All right, so your blood pressure. Look, if you could see me and you, this is me and this is you. If we're always like this, everywhere we go, what's going to happen to our relationship?
If we're like this everywhere we go, we're going to be dependent on each other.
Don't fucking lie and shit. If your
if
husband,
we go like that all the time, we're dependent on each other.
If your husband was attached to your ass 24/7, what would happen to your relationship? Don't lie.
Oh, you think it will dissolve? Like something
will
happen?
It will. Of course, because people are
gonna
get
closer together. What
no, that's
be
bullshit. That's bullshit. People gonna get tired of each other. What if you moved to the other side of the world? Your relationship was like this.
It would definitely be divided and definitely wouldn't work.
Oh, I love you even more, Maureen. She says she don't have a jealous bone in her body. I like that shit. So that's how you look at your blood pressure, though, Starshima. if your systolic and diastolic are this close together, or your systolic and diastolic are that far apart, bad shit's gonna happen between you and your relationship of your patient.
I agree.
Does that make sense? What I'm saying?
I agree with you.
But
I'm
that is called
listening.
that is
Pulse
called
pressure.
the pulse pressure. But that also talks about the map.
Yeah.
So what is the map? Think when you think about the map, what is the purpose of the map?
Look, your mean arterial pressure,
Yeah,
the
but what
pressure
is
that's within the arteries.
right? So CPP stands for what?
Color people's property. I'm just kidding.
I like that. You said that,
I'm
not me.
sorry. I'm
Yeah, I
just
like that.
playing.
I
I
like
just
no, I
have to
like
add
that.
a little
I
light
like
to
that. That's
this.
good.
I'm
I like
sorry.
that shit.
Oh, Kevin, you are too
I was
much.
gonna say something else, but okay.
What was you gonna say?
I'm gonna put in the chat box because I don't want to get in trouble and shit.
Okay.
Cause you
Tell
know I
us
got
about
it. Cause
CPP,
you know,
Kevin. I'm sorry,
cause
I
you,
digress.
cause you know I got a dirty mind. You see what I put in
Okay.
the chat box?
No, hold on.
Oh,
Oh my goodness, you are crazy. You are.
You started it. You started.
Oh my gosh, Kevin.
CPP stands for cerebral perfusion pressure. Cerebral perfusion pressure.
CPP. Yeah,
CPP. How much blood flow you have?
to the brain.
MAP minus ICP equals CPP.
MAP minus ICP equals your CPP.
So what is the
ICU
normal?
nurses, y'all need that. Y'all
What
need
is the
that
norm?
ICU
What is
nurses.
the normal ICP?
Intracranial pressure.
What's the normal?
Sorry, my children are
It's all good. It's
distracting
okay.
me. You said the average number of the ICP.
What's the normal? What's the normal ICP?
I don't know. Tell me.
10
Tell
to
us, Kev.
15, 0 to 15, 0 to
I was gonna
15.
say 12.
Yeah, that's okay. Just say 12. Say 10, because that's the one I usually teach people. Just say 10. What's
It
the norm?
is
What's the normal math?
less than or equal to 15 in adults.
Right, but just say 10 because it makes your math easy.
Okay.
What is the normal map?
The map should be between 60 and something.
So 60 minus 10. 60 minus 10 is what? Right?
Kevin, you
No, but
check
that's
our
what that's
arithmetic?
how you no, but that's how you calculate the CPP.
Okay.
You get what I'm
CPP.
saying?
I
Map
got you.
minus ICP is the CPP.
I
So
see
if
a
you're
lot of ICU nurses
yeah,
having
but
to know how this.
why don't ER nurses know that shit? Because we take care of ICU patients.
I agree, we do, and I think now they hold a lot more. But typically, in an ideal world, we would like for our ICU patients to go up to the ICU
Yeah, but that's
world
not we're
to
not in
be
an ideal world
stabilized.
anymore. Yeah, but we're not in an ideal world
Yeah,
anymore.
I know. I used to, when we have to measure CVP and all those things down in the ER, it was
Right.
always like, because we didn't do it all the time,
Right.
you
We
have to
suck
really
at
stay
it.
abreast on your skills.
Right.
Yes, yes, yes.
I'll stay upon your breast. Don't worry. All right. So what is the what is the drug that you can use or solutions that you can use since we're on medications to manipulate your ICP?
Mannitol,
Right.
hypertonic solution.
Right. 5% saline, 23% saline, mannitol. But mannitol is one of the only drugs that if it's at room temperature or gets cold, has crystals in it.
Mm-hmm.
And what do you do to administer mannitol?
You need a filter.
True, that's true. But what do you do about the crystals inside the mannitol before you administer? You warm it.
Can I admit to something? In all my years of nursing, I've never given mannitol.
I got that. The reason why I gave it because I worked in the trauma ICU, so we gave it quite often. I dealt with bolts. I don't know if you know what bolts are. Bolts.
Bolts in the patient's head.
Do you know what a bolt is?
The thing that they bolt to try to keep the skull in place.
No, it's a bolt that you put inside. You too, Maureen. I love you too. Thank you. You can always catch up on the recording later on, baby. And Starshima knows how to get a hold of me. So the bolt
She
goes
says she out. Maureen's out. You scared her away.
Right. So the bolts go inside the head, and they put in a catheter that goes into the ventricles. It looks like a Foley catheter, but it's a little bit smaller.
To help with the pressure.
Well, we can drain the CSF. We can put it back in. We can monitor the ICPs continuously. We just call them a bolt.
I thought you was talking about like a true bolt. I was taking
Well,
you
it looks like a bolt. It literally looks like you drill a hole in the head and you screw that shit in like a bolt.
Mm-hmm.
I don't remember what the technical name because it's been so long, but I'm sure somebody out there knows what it is. But you know, that's what we did to manipulate it with mannitol and stuff like that.
To help take the pressure off
Yeah,
the
to
brain.
help decrease the ICP and stuff. All right,
Mm-hmm.
so how about this? So we talked about potassium, insulin, nitro. How about chemotherapy? That's one thing I don't know. So if you have any of the chemo nurses out there, we would love your experience because I'm not a chemo nurse. I don't want to be a chemo nurse because I love my fucking long hair and I don't want that shit to fall out.
So you think being a chemo nurse, you will have some side effects because you're administering the medication?
Well, because every time I ever went to a chemo floor, just my experience, I see the chemo nurses not wearing what?
Gloves.
And they administer the chemo or they're emptying the Foley bags and the Foley urine gets on their hands. And what is inside the Foley? The urine.
Chemo.
Yeah,
Drug.
see,
The
yeah.
drug.
So I mean, it absorbs into your skin, so that you can see their hair falls out. They get kind of older looking and shit. So
Hmm.
that's why I don't want to be a chemo nurse.
Do you think that helps them prevent from getting cancer later on down the line, or do you think it
Mhm.
increases their probability?
No, that's a good damn question. I'm gonna research that now. I see a new. Yeah, that's a good damn question. That's good.
I mean, methotrexate and all
Yeah,
the other
yeah.
drugs.
Who else? Well, yeah, but what other floor gives methotrexate?
OB gives it.
Yeah, L&D gives that shit all the time.
Yeah,
So yeah,
atopic pregnancies.
yeah, that's
It's
right.
definitely a treatment
That's right.
for it.
Yeah.
Yeah,
So
absolutely.
and then the H is for heparin.
Heparin,
But how do you give heparin?
IV or subcutaneous in
But if
the
you give it,
abdomen only.
but if you give it IV, how do you have to give it? It has to be how what?
Well, you shouldn't
What
push
is
it. It
the
should be
dose?
given
You can push it, but what is the dosages? If you did push it, it had to be a slow. Like let me
slow,
look this.
definitely push, right?
Yeah, yeah. I'll look it up too, but it's units per hour.
Yes, heparin
And
is in units, not
but
in
milliliters.
kilograms.
But this is where nurses make a mistake because the doctor will order, and I'm just making up numbers. The doctor will order like 840 units per hour.
Mm.
But what
Mhm.
will the nurse put on the pump?
You said
And
that
this
the doctor ordered how many units per hour?
840 units per hour. And
Mhm.
what do you think the nurse might put on the pump?
Hopefully,
They'll,
she put.
they'll no, I'm not kidding. I've got many stories. I can send you links and stuff. 840 milliliters per hour.
Oh no, no, no! You would definitely kill a person
I
because
know, but
they.
at what point would you say, man, I just started this bag like fucking 15 minutes ago and half the bag's fucking empty. And maybe you should stop that son of a bitch. Like, I don't know
Critical
what,
thinking.
so I don't know why people do that, but I tell you, I got stories upon stories where nurses run it at milliliters per hour instead of units per hour.
Right. Well, the pumps are. Well, here's the thing: that the pumps are set to run at milliliters per hour, right?
Right.
MLs per hour.
But if you're giving drugs, you should put it as, you should go
Yeah.
and type in the drug. You know, that's why we have these new, we
Pump.
have these new pumps that you can. So the reason why they still have flushing, I don't even know. If anybody's ever out there, you could tell me because I haven't seen this for a long time. But they still have in the drug book the IV push for the line flushing. So if you flush your line with heparin, which I haven't seen in a long time,
Well, when we
you
DC like ports.
yeah, but that's different. But I mean, I get that. But like in the old days when I first started, the what we would give is heparin. We would have a 3 or 5 cc syringe and it would be 100 units per ml.
Mm-hmm.
And so if it's a 5 cc syringe and it's 100 units per ml, you were flushing the patient with 500 units 3 times a day. So you're giving like 1,500 units a day. And they didn't need that shit. So,
Mm-hmm.
but I don't know if people are still out there doing that, but it's still in the drug book. Because sometimes, like you said, with the ports, you may have a doctor that will order 10,000 units of heparin to sit inside the central line.
Mm-hmm.
So what do you tell nurses who are dealing with central line ports? How do you know that heparin is inside the port?
Oh,
How would you know?
in a central line.
Yeah, like a Mediport or a dialysis catheter or any central line. How do you know that the doctor didn't order heparin to be instilled and just set there to keep from clotting? How do you know that? Pick
But it,
lines.
Well, how do you know? You should definitely check your order.
Yeah, what if the nurse forgot to write the order? What if the nurse? What if there is an order, but the nurse didn't document that she flushed it? How would you
Well, that's
know that? How would you know?
the way that the blood look when it come out.
Yeah, but the problem is most nurses want to flush their central lines before they what? Draw back.
Withdraw blood. Yeah.
So I always encourage them to draw back waste before they flush it because you don't know what's
Mm-hmm.
in the line. You don't know if there's medication in the line. Draw back first.
Mm-hmm.
So that way you don't kill people and shit.
Right.
Oh,
It's true. That
yeah.
is true. That
All right.
is so true. So we went through all the pinch, right? So
Right.
this acronym pinch, it must mean something really to you. What are these drugs? Are these commonly used drugs?
These are high risk medication drugs. All of them are high risk.
High risk medication drugs, and
Shit that can kill people.
that can kill people. So
Yep.
it's good to have safety checks and knowing the indications of why you are given these medications, what are your nursing implications, and doing good nursing assessments around these medications and being able to calculate dosages. One
Right.
big thing I also say for these high risk medications, things like heparin when you're doing 2 nurse checks, things like potassium, or even insulin, more so when you're doing these 2 nurse checks, make sure the nurse is checking it with you. And if you're the
Right.
nurse checking it, make sure you have the order, make sure you're looking at it, because again, you never know what kind of day someone's having, what someone else's workload is like, and with that they can draw up the wrong medication in the wrong syringe, just bring
Right.
it to you if it's all clear. Right?
Mhm.
Like,
Right.
so you don't really know what it is. It's important for you when you're signing off, when you're double checking, that you lay eyes on it, that you do the calculations yourself, because yes, it looked like you're just verifying, but you're also signing yourself off as well. And when we do these things, we're really setting ourselves up to deliver safe, quality care to our patient, decreasing our risk of litigation, and not allowing us to be in
Yeah.
the numbers that are
Yeah.
trending today around nursing.
Yeah, I agree because if I'm giving insulin and I'm going to give 10 units, I technically should draw it up in front of you.
Mm-hmm.
You're
Yeah.
supposed to check the vial, you're supposed to check the syringe. And if I draw it up in front of you, you can see what I'm doing. You can see the medication, you can see the syringe, and you could stop me before I make an error.
Yep.
But if you don't and you just sign off saying I did it correctly and I make an error, you just got in trouble for falsification of charting. And that can
Mhm.
cause you to lose your license. Because
And it ain't worth
that's considered gross negligence. So.
it. Mm-hmm.
All right. So before we end, because I know we're almost at the hour, you can give the answer. Remember earlier I asked, you have metoprolol, low pressure, and Toprol XL. What do they all have in common? What do they have in common? Now you can give the answer.
I'll put it in the chat. They are the same drug,
Just what?
different names.
Right. Different names. So
So
you
they
got to
all
know.
do the same thing.
Right. They're all beta blockers. They affect. So that's the problem. It's like, oh, if you don't understand medicines, we're going to be in trouble. I'll give you an example. I'm your patient and I'm like, Starshima, I got this fucking dry cough. Why do patients with beta blockers get a dry cough?
Beta blockers and a dry cough.
That's a big complaint
work
with
on
old
the
people.
beta.
So
It's
what? Right.
blocking
So where are your beta receptors found at?
lungs.
Right. You got beta 1s, which is found in your heart, and beta 2s found in your lungs.
Mm-hmm.
So what does it do to your lungs that causes the patients to have a
Dries
cough?
up that surfactant. No, I'm just
Oh, look at you. That's right. Look at that. Boop, boop. So what do you do to your patient? You go to say, listen, Granny, do you want to fucking die of a stroke or do you want to have a dry cough?
I'll take a dry cough.
All right, then take your medicine and shut the hell up. But if you understand how your medicines work, you're more likely to educate your patients better and they'll understand it and they can appreciate. Because we're not going to be able to get your blood pressure down and keep you from having a dry cough.
Right.
Drink some damn water, Granny. You know what I mean? So I know, but that's why it's important.
Moisturize.
Right. Moisturize your throat, Granny.
Oh my goodness, Kevin. What do I get?
I told you
into?
I was on fire today.
You
I
are
warned
on
you.
fire today.
I warned you.
Moisturize your throat, Granny. That's what I would say to her. Moisturize your throat, Granny.
Look how red I am today and shit. So.
Yeah. Fired
I'm
up,
on
fired up.
I'm on fire today, man.
Yeah. So tell them, you had a big question for them of what was the antidote to beta
Oh,
blocker
that's right. What
toxicity.
what is the antidote, Starshima, for
Well, I'm
beta blocker
asking
toxicity?
Kevin, what is the antidote?
Glucagon.
Yes,
All right.
bingo for
That's
the
right.
win, Kevin.
That's
You
right.
win a Kevin and Starshima coffee mug.
Oh,
Woohoo!
now I do have a question though, because somebody on Facebook said, was that you? Somebody put it on their glucagon. That's good. Whoever that is,
I think
Facebook
I
user,
did.
that's good. That's good. So, but I want you to know that we did our last podcast, and I don't know if people paid attention. I don't know if you remember what in our last podcast we put up there that people could win something
Hmm.
if they put in the Facebook chat the exact words. Don't be bullshitting us, and don't be putting some stupid words in there. The exact words that came out of Kevin's mouth, you would win a what?
You will win. I think it was a T-shirt or a mug. You were going to send
Both.
it to them.
Both. I
Oh,
said a T-shirt and a mug.
right.
So, but I don't know if we advertise that when I post it. I don't know how you want to advertise that, but just remember that so people know.
Well, let's just advertise it now. We got 2 people on
Yeah.
here. Won't you
So,
ask them a question so
our
we can
previous,
send them a mug?
yeah, but our previous podcast. Oh, all right. So you want me to ask?
Then
I'll
we have
ask
some
it.
people on here. This is our live show.
All
Kevin
right.
and I are anticipating going live more often and recording for
So
y'all.
let
Jane
me.
has suggested that we go live every week.
Somebody
drop
else
a
said they
live
wanted.
show for y'all.
Yeah, somebody else said they wanted a morning show and shit. So
Yeah, they
How
want a
ear-
morning show. Can
how
y'all
early?
imagine waking up to Kevin and Starstream your weekly
Yeah,
morning, your
I
daily
don't.
morning show on
All
your
right. So
drive to work or your drive home from your shift?
all right.
Tune
So
in to Kevin and
here's
Starshima.
here's my question. This is antibiotic medication, Cipro.
Oh shit, bro.
How long does it take? How long do you have? What's the maximum amount of time or the minimum amount of time, whatever you want, that you have to infuse IV Cipro? How's that? And that's from the Davis Drug Book. The answer I have is exactly from the Davis Drug Book. If you're going to give IV Cipro, not PO, but IV, how long must you take to infuse the IV Cipro?
Can I answer it?
No, because then how are you going to let the people win and get their
Oh.
T-shirt and mug and shit?
Oh,
I'll buy
thought
you one
would.
too. I'm still waiting for mine. You haven't even bought me one and shit. So next time I can wear it and I can drink my Coke in my mug.
Exactly. Shasta. As long as it ain't Shasta, then it'll be
You
cool.
even know what? Do you know what RC Cola is?
I know what RC, the red and blue can. Somebody
Facebook
said 4
user.
hours.
Yeah, that's too long. That's too long. Good guess though. That's a good guess. Even
Type
if you
your
were
name
right,
in. Who wrote 4 hours? Type your name in. We
yeah.
can't
Even
see
if
it.
even if you were right, it just says Facebook user. So I don't know who that is. So why are you
name
trying to
in.
hide? Yeah, why are you trying to hide and shit? Who are you hiding from? Should I call the
Probably Kevin.
police?
They hide from Kevin.
Should I call the police on your Facebook user? But that is a good guess. It's not technically correct, but that's a good guess.
I mean, it'd be safe, right? Like to give it.
Yeah, but that's too.
time.
That's the.
1 hour sounds good.
Yeah, but I still don't know who the hell you are because you don't
60
have a
minutes
name.
sounds good.
Yeah, but
Did
I
you
don't have a
Google
name.
it? They
Google
don't want
it.
to be known.
If you say you Google shit, don't say I Googled it because that's not a valid medical reference. Oh,
It's
Nikki B.
Nikki. What's up, Nikki?
Nikki B. Wait, who you trying to hire from, Nikki? What the hell,
Nikki
man?
B. 4 hours. I think 60 minutes sound good to me. What do you
60
think,
minutes
Kevin?
is correct. That is correct. 60 minutes is correct. That's good.
Nice. We got some good season nurses
So
in here.
don't forget that though. So now you got to send the coffee cup and the T-shirt to Nikki.
I thought you were going to do it.
I don't know. You got the damn link. I don't have the link. You didn't even give me the link to the store and shit. It's like you a control. Yeah, you like a control freak and shit.
I'm a control freak. I got it on lockdown. Everything filters through me.
Open that shit up, baby. Open up that OPP. OPP.
Other people's property.
Yeah.
Oh my goodness, Kevin. This
Oh
is
shit.
hilarious. So, y'all, we are anticipating to come back and visiting y'all on a weekly basis. Our podcast manager has really been challenging Kevin and I to get more in the face and in the front of you all, and for us to come with game-changing content. As always, we always would love to hear what are some of the things that you want to talk about. We want to talk about things that are hot, that are trending. We want to have fun. We want to use our voices to be able to drive a greater impact in the world.
Next time we're
So,
going to talk about a particular nursing procedure and how to do it properly.
oh, that
But I
sounds
won't.
fun.
But I won't tell you which one.
Okay, but you got to send it to me so I can do my research
Yeah, I
in the
will.
in
I'll send it.
Kevin's voice.
I'll
Kevin
send
be
it
in my
to you.
DM, y'all. He be like, "What we talking about?" So I can do my research.
Well, I want to make sure I'm up on my stuff and I don't just talk out my ass.
Well, hey, I just shoot it from the hip out here, y'all. So what y'all see is what y'all get. I'm sorry.
Yeah. I
All right,
remember.
Kevin. Well, go
I,
ahead.
remember, I'm Robin. You're Howard. So I got to do my research.
Oh no. We
Oh,
got to flip the script. I'm
Nikki says
Robin.
she knows what it is. What is it, Nikki? You say you know what it is. What is it?
The procedure that he's gonna do.
The procedure? What are you talking about?
Is she talking about for the next
We'll see.
podcast?
We'll see what she's on. Let's see if she gives us an answer and stuff. Mm.
I'm
If you
sure
have a
she will.
particular, yeah, if you have a particular procedure, you can always tell me. I'll cover that shit too. We
So
can
if
do
you want to know how to
pacing. We
measure
can do.
end-tidal CO2,
Oh yeah, bladder. Yo, oh, Nikki, I love you. Yeah, bladder irrigation. We probably should talk about
how to
this.
manage a CBI,
Yes, we talked about that too, huh?
what
Did you?
kind of patients,
Yeah.
should they use sorbitol? Should they
Do you? Yeah, but do you
use
have proper training?
to use a CBI? To I
Hmm.
mean to care for a
Did you
patient
know?
with a CBI?
Did you know the state requires nurses to have proper training to take care of a CBI patient?
I did not know that.
Oh,
I've
we
taken
didn't.
care
We
of
didn't.
CBI patients with no
Oh, we didn't.
special training.
We didn't talk about that off air.
No.
Oh, maybe we should then.
We'll talk about it in the green room.
Yeah,
I didn't know
yeah,
that.
yeah.
I've monitored patients. I learned so much about the different type of fluids that we're
I,
irrigating with as well,
I
and the
got that.
shifting at the cellular level. But
Hmm.
I didn't know I needed a special type of
The
training to be
board
able
of
to take care.
nursing would come to you and say, "Starshima, have you had proper training on CBI?" And what would you have to say?
I would say absolutely I did. I got it in nursing school. I'm just
No,
kidding. I'm just
no.
saying.
They
I'm just
said,
saying.
I know, but they said you had to have annual training and
Mhm.
training upon hire. That's what they told the hospital.
Oh, I had it. My organization took care of me.
Is it in writing? What
It's in writing. I've
is it
documented. I signed and dated it.
is it updated?
It's updated.
All right.
No, as of 4 years ago, it's out of date. But
Oh shit.
All right,
All
y'all.
right.
Well, it's been an amazing, amazing night. Thank you so much, Kevin, for another
Thank you,
episode,
Nikki.
and
Thank
thank
you,
you,
more.
Nikki, for
Thank you,
everybody that tuned
Maureen.
in. Are you looking for Maureen?
Yeah, thank you, Maureen. I know you're not here, but when you come back and listen to the recording, just hear my voice, baby.
Kevin, you're gonna get us in trouble. All right, y'all. Thank y'all so much for tuning in. Have an
Thank you,
amazing,
guys.
amazing night. You gonna send us out with some music?
Yeah. I love you guys. Thank you. Don't forget to go and see Starshima at Brand Nurse Coach on Instagram, Facebook, and you can visit us at Central Valley Medical. I appreciate you guys. Woo,
Yeah, go
woo.
get your ACLS, your TNCC,
Mhm.
and don't forget to hire Kevin as your coach.
And don't forget, snitches get stitches.
Oh my God. Good night, y'all.